right, for our next talk, we move to a very different discipline, but one that is obviously also directly related to human life, its protection, and the difficult ethical issues that arise in that practice. We're very pleased to have our beloved Dr. Richard Honsinger to give us a talk today on medical ethics. He's well known to most of this audience, but we'll give him a brief introduction in any case. Well, I didn't know the following. So Dr. Honsinger received his bachelor's from Washington State University and MD from the University of Washington, where I spent part of my career, and went to the University of North Carolina, Chapel Hill, to practice internal medicine, and also back to the University of Washington for his allergy and immunology fellowship. Of course, he's been here practicing medicine in Los Alamos for 53 years, right now at Los Alamos Medical Care Clinic, where he helped diagnose my son's allergy to peanuts. And also his non-allergy to almonds, which my son is very excited about. He was a clinical professor at the UNM School of Medicine, co-medical director of respiratory therapy at Santa Fe Community College. He was on the board of directors and a fellow of the American Academy of Allergy, Asthma, and Immunology, on the board of directors of American College of Physicians. He's been president of the Joint Council of Allergy, Asthma, and Immunology, principal investigator of multiple research studies, was an advisor to the Food and Drug Administration, and on the editorial and review boards of major allergy and immunology journals, and on the advisory board of UNM Los Alamos for 20 years. And of course, he is a devoted and beloved member of our Immaculate Heart of Mary Parish Catholic community. And it's my pleasure to present Dr. Richard Honsinger to tell us about his perspectives and experience on medical ethics.
Yeah, thank you, Chris. I feel a bit out of place here. When I do science, even if we do two studies, we don't get the same answer. In medicine, it's part of biology, where you folks are in science is more solid and you get the same answer over and over.
No.
Ours comes out, no. Somebody says no. And then you ask me to speak after a world-class scientist and before priests that have much better jokes than I do.
No.
I heard some opposition there. And as you know, I've been around for a while. We came to Los Alamos because we were looking for a place to raise our family. Had 5 kids when we came here, started having kids just after during medical school. And we were looking for a small academic community. I trained at Chapel Hill and thought that would be it. The politics of North Carolina did not agree with us, and they did in New Mexico. I was assigned to New Mexico with Public Health Service for my military time, and I was here as an epidemiologist. And we came to Los Alamos, and after being in the South, where our Catholic Church had a cross burned on its lawn, we were much more comfortable in a community that had such an appeal to people of various races, various religions, and ethnicity. I remember when my wife was walking around the plaza in Santa Fe carrying our 4th child, that she didn't tell anybody about when they were in North Carolina. Some elderly man, Spanish man, came up to her and blessed her. And she said, "This is the place we're going to be." I'm not an ethicist. I didn't take very many courses in medical ethics. In fact, when I was a sophomore medical student, I was concerned that we weren't getting any medical ethics, and I went to the dean and said, "Can't we get a medical ethics class?" And we were told, "Your schedule's full. I don't have any place to put another program in. I don't have any funding for it. But if you want to do one, you can." And so we got a group of us together, and we had a rabbi and a priest and an obstetrician, a lawyer, some various people come talk to us, and we had our ethics class, and we had about a third of with a medical school class that came to listen to it. So we started out sort of looking at medical ethics. The AMA started, this is where you can read it here. The AMA started in 1847 and was founded to establish a code of medical ethics for medicine. American College of Physicians, the organization that I've been active with, is the largest specialty organization in the world, actually, with close to a couple 100,000 physicians. And we put out a guideline of ethics and medical ethics guide that has been updated several times since we started it in 1984. When I was on the board of the American Academy of Allergy, Asthma, and Immunology, we put together an ethics committee and found a physician who was a Catholic physician in Albuquerque to head our ethics committee. And so that we've been involved in ethics. And then I've been in the ethics committee for the Los Alamos Medical Center for a few years, and that's been very important this last 2 years. Ethics goes back a long ways. At first, in medicine, there was the cult of Asclepius that the Greeks had. So the son of Apollo, the Greek god of medicine. And there were temples of healing. There were some down in the Peloponnesian Peninsula at Epidaurus, at Corinth, Pergamon, Kos. At Pergamon, the Romans kept an active medical facility there through their years with a fellow by the name of Galen, who was sort of the father of medicine. Hippocrates was on the island of Kos, and he came out with an oath that he had his students take on medical ethics. And somebody brought me back a copy of Hippocrates' oath with a leaf of the sycamore tree that he supposedly taught underneath. And the Hippocratic Oath was initially started with Hippocrates, but then the World Allergy Organization in 1948, after World War II, put together another oath with the Declaration of Geneva, and there were something like 60 countries sent representatives to that convention, and they came out with the Declaration of Geneva, which were the Hippocratic Oath that most medical schools now use. It has to do with service, it has to do with patients being first, dignity, diversity, confidentiality, good medical practice, and honor, collegiality, teaching, and personal care, human rights. And at the end, you swore to that oath. And medical students still do that today. There are 4 medical schools in the U.S. that don't use the oath. They use an oath of Maimonides, who was a Jewish physician during the Dark Ages that kept medical ethics and some medical research alive. And in ethics, if you take any ethics classes, you realize that you're always told there are 4 pillars of medical ethics. Beneficence, which is doing good, non-malfeasance, do no harm, and autonomy, that is, the patients have a choice, and to ensure fairness. And you don't know if it's out of chance or why, but there are 4 pillars in the back of the U.S. Supreme Court. Whether that was just an accident or whether it was intentional, I'm not sure. World War II made us think more about medical ethics. The Nazis were active with euthanasia in their camps, where they put Jewish people and Catholic priests and the gypsies. There was a trial afterwards, the Nuremberg Code. And the Nuremberg Code was in 1947, when they had the council at Nuremberg with the trial of 20 doctors and 1 other person. 12 ended up with a death sentence, 6 went to prison, and 3 were acquitted. And after that, it was looked at what we should do and what kind of a code we should have for medical research. We were doing medical research that harmed the patients without concern for them. And so now we have informed consent. The results shouldn't be obtainable by other means, and rather than experimenting on patients. Animal experimentation should precede experimentation on subjects, and we need to avoid mental and physical suffering. We should not expect death or disability from any experiment that we run on a patient. The risk should not be effective. We protect the subject by qualified investigators who have experience, and patients are allowed to withdraw from research at any time. The study is terminated if you find that there's a reason that you shouldn't be doing that study. And we terminate studies for two reasons. We terminate if the drug looks like it's much more effective than we expected, and we shouldn't keep people on placebo, or we stop it if the drug looks like it might be harmful to people. So there was initially the Declaration of Geneva by the group that became the World Medical Association. And then in 1964, there was a conference in Helsinki where we looked at the various, at the research that was done, clinical research, to see how we could better do clinical research and apply ethics to clinical research. And that's still used, and we use it and we have to sign on to it for every research study that we do. It goes through a periodic revision, but it's now in its 7th version, but we still use the Declaration of Helsinki for medical research. And in 1966, we formed institutional review boards. An institutional review board, I'll get to in just a minute, but it's something that is looked at before you start any research study. And then we were required in the US, if we do a research study that involves human subjects, we have to register it on clinicaltrials.gov. That's made a difference in the research that we do. If you have a drug and you want to study it against another drug, you have to publish what you're doing. You have to let people know what you're doing. With that, the pharmaceutical companies have sort of stopped doing drugs comparing themselves to a competing drug. If your study comes out wrong, people are still going to know it. Before it came out wrong, you didn't tell. The institutional review boards look at medical research, and our medical research goes through several phases. Phase 1 starts with animal experimentation, trying it on a few people, paying them to take it, making sure it works, making sure it doesn't harm them. And then you go to phase 2. Phase 2 studies, we've done a few of them here in Los Alamos, where you develop the drug and you work out the dose of the drug. You give it to a few hundred patients to make sure that it's a safe drug. And then you go to phase 3. Phase 3, you give the drug often to thousands of people. You look at the drug to see if it's effective. You look at it to see if it has side effects, and you somewhat work out the dosing of it. I've had a few phase 2 studies and multiple phase 3 studies. Been able to do that because we're in Los Alamos. A small town like this shouldn't get that many patients. We shouldn't be able to do large volume research. But the studies I did turned out well, and they turned out well because of you. I would go to Santa Fe, where I also had an office, and I'd ask a patient if he wanted to participate. And he'd say, "Doc, I don't want to be no guinea pig." I'd ask a patient in Los Alamos if they want to participate in a study, and they'd say, "Let me read the protocol."
Exactly.
And then they couldn't believe it that we had 100% participation, and the records were so well kept that they would give me another research study. We did a study about 20 years ago where we looked at your kids in middle school, and looked at the middle school kids, and we asked there were 600 kids in the middle school at that time, went in and taught their biology class with the pulmonary function test to see what their lungs were like, and then sent questionnaires home with the kids, got back almost every questionnaire 5 out of 99 patients participated, students. So it was a great participation. And the record keeping was excellent. We did allergy tests on the kids that had asthma. That was 60. We brought in another 60 kids that were case controls. And the kids all participated with allergy tests, blood tests, pulmonary function tests, challenges. And we got a nice paper out of it. And thanks to you folks and your interest in science, it turned out well. And then there are phase 4 studies. We've done a couple of phase 4 studies. Phase 4 studies are looking at a drug once it's been approved. You can look at the drug and say, is it helpful? Well, maybe it has a side effect we want to explore a bit further, but we think it's safe enough and needed enough to be on the market that the company is compelled to watch patients on this drug afterwards. And we have one of our asthma drugs that the people in the control group didn't have as many heart attacks as the one in the research group. It's a large study. We took it to one of the university's epidemiology departments. They looked at it and said, golly, your controls didn't have any heart attacks. They didn't meet it. They didn't come up to the norm. And yet your patients were at the norm, so it's statistically significant that there were more heart attacks. We felt and the FDA felt that this was probably a policy of the study. But they made a phase 4 study. We watched patients, and they came in twice a year for about 4 years. Well, we watched their cardiovascular disease, did tests on them, and got their histories and exams. And eventually the FDA dropped that warning that this drug might cause heart attacks. So the phase 4 study was helpful to us. We were able to help a lot of patients while we were doing it. The Institutional Review Board is a group that has to review studies. Something that was started back in the 1970s and the 80s. Before that, we didn't need to go through an approval to get studies. Some of the studies that I did back then, or the experiments we did back then, might not be approved now. Those patients that were allergic to bee venom and would have reactions, we mixed up a concoction of bee venom and gave them shots, and then brought them in the emergency room, started an IV, and had a beekeeper bring in a bee, and we'd sting them. And it showed that our desensitization worked, and now we can get those bee venoms commercially. But it was useful, but we did not go through an institutional review board and all the consent forms and such that we have to have. Institutional review board has to have at least 5 members. One of them has to be a scientist. It has to have a community member, and then you have to have some non-scientists with other concerns. And so we started doing some studies. Here we went through an institutional review board. I remember we got one of our non-physician members I won't give his name, but he was a lawyer. And I put together a consent form and gave it to him and gave it to the board, and they said, oh, that's wrong, you have to redo it. So we redid it, changed the wording a bit, went back and gave the consent form, which tells the patient the warnings of all the things that might happen, and gives them the option that they can turn it down, or they can drop out if they need to. And we brought it back and turned it down again. So took it back and rewrote it again, and went back and took it to the board, and they approved it. It was the original version. And your institutional review board gets reports periodically how you're doing on your research to make sure you haven't found something that turned out that may harm some patients. And to try to get medical ethics, more awareness in medicine, there was the DeCamp report. This was a foundation that in 1983 had a conference in Dartmouth. It was in December, but it took them another year to put it together and a few more months to publish it, so it didn't come out until 1985, and probably our major research journal in the US is the New England Journal of Medicine, back in the world, and gave us the recommendations for medical school curriculums. The medical schools should have moral considerations, they should understand valid consent, They need to know how to proceed when the patient is not mentally competent and able to consent. They need to know how to proceed when the patient refuses treatment. What do you do when they don't want to do something that might help them, or might not want to do something that might help other people? And when is it justified to withhold information from a patient? When is it morally justified to breach the confidentiality? People can confide in us, almost like the priest, and there are times that if you see that they're going to be harm coming to somebody else from that information, what do you do? So we have to learn to take care of patients who are not going to do well, and follow them through till death. There was a Romanel report in 2015. Romanel was a professor of philosophy, was around various universities. He seemed to move every few years. He spent, I think, 4 or 5 years at UTEP, at the University of Texas at El Paso. Finally, in his last time, he was chairman of the physics department at the University of Maryland. And I don't know where his money came from, but he left a lot of it as a foundation. I don't think it came from teaching. He established some lectures, and he established some fellowships in medical ethics, and then so that he sort of helped medical ethics get off the ground. They had a report that after a conference they held, and this was to look back and saying, okay, are medical schools teaching ethics now? Are we getting physicians out that have good medical background, or have good medical moral background? And they put forth the progress in medical ethics and professionalism, and we have something in medicine where it keeps your medical schools approved, just like you do with your grade schools and your high schools in Los Alamos. You have to have them accredited. So you want your students who graduate from an accredited medical school. You know, we lost our neurology surgery program, or neurosurgery program at UNM, because we couldn't meet the requirements of doing things that neurosurgeons should do. They were too busy taking care of people in the emergency room and not getting enough some other experiences that they should have in neurosurgery. That program has been built up again with a little bit better spectrum, but you have to go through the ACGME, American Accreditation for Graduate Medical Education, to get your medical school certified, and get your specialty program certified. And this report came up with 6 core competencies that medical students should have. That is, they should be good in patient care, they should have experience in medical knowledge, interpersonal and communication skills, practice-based learning, systems-based practice, and professionalism. And professionalism is basically medical ethics. That they have to be beneficence, they have to have them do no harm, they have to do the patient autonomy, and we have to make sure that we have good decisions and justice. And they came out with their sub-competency requirements that every medical school has to pass when they get their inspection periodically to keep themselves accredited and to turn out students that have diplomas that are recognized. And medical ethics gives us problems of what we can do, problems that we have, problems that Ray brings up the church has about these issues. Certainly the racial issue, the Catholic Church has usually been on the right side, the ethnic issue, religion, we allow people to have other religions, we don't let that interfere with their care. And then there's the conflicts of interest. Right now, financials are a big one. I put a paper together a year or 2 ago on the copay. That the copay of insurance sometimes takes people so they won't buy their medicines. One of my patients said to me, "I'm so glad when I go into the grocery store that they have both food and medicine, because I can decide which to buy." And so when there's a high copay, patients don't take their medicines as well. And there have been a couple of studies looking at that. Louisiana Blue Cross system decided they weren't going to charge a copay for medicines that have to do with cancer, diabetes, asthma, and blood pressure. Things where taking a drug makes a real difference in whether the patient is hospitalized or whether they live very well, and found that it actually saved the insurance company money to do the copay. Fewer emergency room visits, fewer hospitalizations. And if we can just get the rest of the insurance companies to believe that charging patients sometimes makes them so they don't accept therapy that might otherwise make the system even cheaper as well as better. We haven't. So we have the financial, we have education conflicts. Well, we, of course, have a research, one that comes up in medicine, particularly now, that everybody that's worked at the laboratory has a possibility of being disabled from some exposure, which may or may not have happened. And they want you to sign off that their illness is due to the laboratory. And so we have to be honest as we look at disability. We may have to, the judgment is, would you honor what your patient's wishes, or you honor what you think are the science wishes, and you try to keep your moral ethics correct there. And I lose some patients over that they go to find someone else that will sign their form for disability. I think that if you can walk and you can do well, you shouldn't have a handicap permit just to get you to park closer. Handicap permits need to be saved for those that need them. There's some patients that don't feel that way, but we have to, with our medical ethics, saying that this is the right thing to do. We ask physicians in sexual involvement. It can be a problem in medicine, as it is in priesthood, it is in every other discipline, and it's something that we have to watch. I have had times, and so in medicine, we say that you should not have a relationship with your patient. And I've had times that a doctor has called me and saying, would you take this patient over for me? I'm going to date her. And so you'd get the patient to transfer care, so there could be a relationship there. And we have our, that brings up whether we're going to do things for professional values or for personal values. Confidentiality is something that comes up now in medicine. If I have a patient that's happened to us, who the patient had syphilis, and his spouse, or spouse equivalent, needed to be told, needed to be known that she should be checked for syphilis. He wouldn't tell her, and so someone had to tell that person. We couldn't release the information. You have confidentiality, but we find some way to let her know that she ought to be checked, not necessarily where it came from. Of course, I know she must have suspected that as well, and I don't know what happened to the relationship. But we felt an obligation to both the patient and the patient we did not know. So we do have to educate things. Privacy, and privileged communication, and then it's infinite wisdom. Congress gave us a law. And that law is the form that you look at whenever you come to our office. It sort of looks like the form that comes in with your credit cards. And you probably never read it either. I think we must have given out 1,000 of those, for somebody read it and said, hey, you forgot the not. So we do pass the form out, and it tells you that your information is going to be secure, and we're obliged to keep it secure. That we can't talk to you, we can't pass records to other people without your permission, and so we have secure transmission of your records. We use a fax machine. It has to be one that has a secure line. We have to have secure patient portals so you can talk to us and send us notes without other people seeing what you're doing. And there are laws that transfer medical information, and there are some state exemptions. In most states, if a patient says yes, you can send their records to another doctor. In this state, you can send the records, but you have to get out a special form if the records include psychiatric disease. For psychiatric referrals, psychiatric transmission, before I can talk to a doctor about a patient's psychiatric problems, I have to have the patient's permission. And of course now we have telehealth, where it's easier to talk to somebody in Chama than it is for them to drive 100 miles for a visit. And right now with the COVID epidemic, Medicare is paying for that. They pay for it until the COVID epidemic is over. Right now that's supposed to be January 11th. We're pushing Congress to extend that again, because they've extended it several times already. But we can still do telehealth for Medicare patients. And so telehealth is something that we have to tell the patient at first. You know, they're not on a secure line. Somebody can get into their Zoom and see what they're telling us, so they have to be informed and agree to that telehealth before we get into the visit. Genetic testing, we're just starting to do more, to learn more about that, and that's going to bring up a lot of problems of medical ethics and medical decision making. Part of the hepatic oath is you should not receive gifts. You should not receive gifts that are going to influence you in the patient care. So certainly we don't take extra money from people saying that they want to essentially buy a decision from us. But we do take gifts. As my nurse will tell you, it's okay to bring cookies. And I did take this gift, which a patient told me that I want to give you a guardian angel that I made. You need a guardian angel. And I do need a guardian angel. This lady has severe Down syndrome, so that was just my desk. And we used to get a lot of benefits from the pharmaceutical companies. You know, my kids drank free formula when they were young because the pharmaceutical company wanted us to remember the name Similac when we went out in practice. And they don't do that anymore. They don't do that anymore because Congress has looked at that and said, this is influence. All of our pens used to have the name of a drug on them. They now have our name, so you can take them home and advertise for us instead. There's one right there, yeah. Yeah. So things have changed, and the pharmaceutical companies have certainly found another way to spend their money, because now they can put it on TV and spend their money on TV advertising and spend it on gifts and samples and things for doctors. We still try to get samples when we can. In our office, we talk to most of the representatives, and we tell them the reason we're talking to you is we want some free medicine for our patients. I'd like to have some free inhalers to teach people how to use those inhalers. So we do accept some things from the pharmaceutical companies, but we try and do it in an ethical form. It's been a problem in medicine where physicians, for a while, were starting their own hospitals. Our heart hospital in Albuquerque was an example of that. The question is, if you send a patient to your hospital and order more MRIs or more CT scans, it makes more money for you. As our hospital become more and more profitable, that is something that now has essentially been forbidden, and the heart hospital in Albuquerque sold to Loveless instead of a group of physicians that owned it. And one of the problems is in medicine is that we don't always do things right. We make mistakes. This came out when the Institute of Medicine, which has now been changed to the Academy of Medicine, part of the Academy of Science, has a group of physicians, most of them academic, that serve on that, and began to look at deaths due to medical errors, and found that maybe as many as 20% of the deaths in the hospital had some relationship to some medical error. You know, there were times that people had the wrong leg cut off. When you look carefully at medicine, some of those malpractice suits really deserve to be there. So we need to try to change the culture of medicine. And in doing so, they tried to make our culture of medicine, using an example of the airline industry, that it's okay to tell when you make a mistake. In fact, when you make a mistake, it's not your problem, it's the system problem. The system needs to be fixed so that mistake was in such a position that it wouldn't have happened. And we've tried to do that in medicine, and the Institute of Medicine has put out several papers. There were white papers and guidelines that have been caught by the press. The first one was to err as human, and then more recently, chasing the quality chasm, looking at medicine, looking at the benefit versus any harm we did, and saying that this should be safety, should be first, effectiveness, patient-centeredness, timeliness, efficiency, and equity, and then more recently looking at making sure that that's taught in our schools as well. As a physician, I've been in practice 53 years. I know I pronounced some of your relatives dead. And we had Dr. Kubler-Ross once came to Los Alamos and actually gave a lecture here. He was a psychiatrist who tried to make death more understandable to people and talked to people about what she felt were 5 stages of dying. So the 5 stages were denial, anger, bargaining, depression, and acceptance. And she went through many cases showing that most people go through those. If you die very quickly, you go through them very quickly. But if you've got a slow death, you can usually measure those, and people, for the most part, certainly our patients that have a slow death and a chronic disease, by the time they get to the end, they've had their acceptance. And that's part of where our priests come in, helping them with that acceptance. And now, of course, we have euthanasia, that is, mercy killing of patients. Started, of course, public vines with a pathologist in Michigan, Kevorkian, who assisted like something like 130 deaths. Went to court over it. I think he's actually served some time. But that's become more widespread. There are now 10 states and District of Columbia that have assisting death laws. New Mexico passed one a year ago. And the first year, June 2021 to June of this year, it has been used 100 times. And so it's there. It's something we have to learn to look at with medical ethics. And is it proper? It takes 2 physicians to diagnose terminal prognosis. And terminal prognosis means you're going to die within 6 months. You have to be mentally able to give that informed consent. You have to get pills. You have to be able to take your own pills. And you don't get the pills until 48 hours after you've made the decision. So that's where we stand with death and dying in New Mexico. Our approach as Catholics is that we still believe in the 6th commandment, and thou shalt not kill. And so I certainly am opposed to active euthanasia. I'm opposed to the death sentence that many states still have. I mean, it's only 2 that were Western countries that have a death sentence: U.S. and Turkey. And we'd like to see us stop that. And of course, you know, all the issues about abortion that are on the TV every day now. However, we've always felt, and as physicians, as caregivers, and as Catholics, that it's all right to use measures. You don't have to use measures that might prolong somebody's death, that might put their death off for a bit. If you're on a ventilator and you're not going to survive, and you decide you don't want to be on a ventilator, we can pull the plug. And so we can not, it's easiest for us if we don't start things. So it's nice to know ahead what you want, because if you don't know, you treat the patient with things they might not have otherwise wanted. I did have one of those patients once. We resuscitated this patient and then found out that the patient had a living will and hadn't wanted to be resuscitated. And apologized to the patient, and the patient said, well, guess it wasn't time. So we stopped the life-saving therapy, and there's no state that even nowadays forbids that. And so certainly we're allowing a natural death, and sometimes what we're doing is really is prolonging that period of the patient dying. That's not beneficial. In our state, you can go to the state health department and get an advance directive. You can get one that comes in, you hang it someplace where somebody can see it when they come in to resuscitate you. And DNR means do not resuscitate. We'll get to MOST in just a minute. And we'd like to have you have a living will. You just don't tell people where all your money and all your belongings and all your treasures should go. And you should also tell them what you want. And so we ask you to have a living will. Yeah. And you may choose hospice. My sister died a few weeks ago, but she'd been on hospice for 2 weeks. Give her much more ready time to die. She was told by a doctor that she had to go through some extra procedures that might help her, might not, or she could go on to hospice. Hospice means that we think that you're going to die within 6 months, and we're going to do things for you that are palliative, things that are comfortable. We promise to keep you comfortable more than to try to cure you. And certainly we have active hospice groups in Los Alamos. MOST is the medical order for the scope of treatment, which is just basically that. You can get a pamphlet on this that has a bunch of pages and a bunch of places where you make checks, and then you have somebody sign it, and that's your living will. So you go to the website of the New Mexico Department of Health, and you can get one of those pamphlets. It's listed as A, B, C, D. A says, do you want cardiopulmonary resuscitation? Do you want do not resuscitate? Do you want medical interventions? And specifies what sort of medical interventions. That is, do you want, if it comes to the point that keep you alive, you have to have tube feeding or you have to have IVs. Do you want that? So you have to it's easier if you've decided those ahead of time rather than you deciding later, somebody else having to decide for you later. Whether you should have hydration and nutrition. Whether you, and then of course you have to swear to it, to basically sign it. And you can assign that somebody else can be your health decision maker. If you have a close relative, a close friend, somebody else that would know what you want, and you can't make your own decision, you can list who can make a decision for you. The American Bar Association put out a pamphlet. It's legally accepted in New Mexico. There's only 4 states that don't accept it. They accept it, but they also have you sign some other forms that their state requires. And that's the 5 wishes. This was put out by the American Bar Association, and it's honored just like a living will. And the 5 wishes this goes again through a pamphlet. I think they charge $5 to send you a pamphlet. And you wish for the person I want to have make decisions for me when I cannot make my own decisions. You want the kind of medical treatment you want or you don't want. You want to know how comfortable you want to be. Some people say, no, I don't want to be knocked out. I want to experience life. I want to know my friends even if I'm in pain. And so you get a chance to sort of tell that ahead of time. And how you want people to treat you. And then you get sort of an open area saying what I want my loved ones to know about me or the secrets I want to tell. Medical ethics is becoming more apparent now as we get into reproductive ethics. In the 1960s, 1970s, we developed pills that would stop a woman from ovulating, so she didn't produce any eggs. Of course, we've always been able to cut the tube that puts your sperm out, and you can have surgery that makes you sterile. So we've had ways to keep the babies from happening, and there are ways of doing things so that when an egg does get to the uterus and it's fertilized, that it keeps it from implanting. That it keeps from some of the medicines, and certainly the intrauterine devices keep that egg from burrowing into the uterine wall and becoming an embryo and becoming a baby. And we have to decide, where it is if we can stop that process at all, where we ought to stop it. We're subject now to a lot of people are having in vitro fertilization, particularly couples who've been unable to have babies, probably because of some problem, that the woman has a problem with her fallopian tubes, where she can't pass that egg very well. You take that egg out of her ovary, put it in a dish, put it in some sperm, and put it back in the baby's uterus, and they have a baby. So we have in vitro fertilization, and then the real problem comes up about how about people that want to keep a fertilized egg. It comes up particularly in cancer patients. A woman is young, she has a lymphoma, she has some type of tumor that's going to take large doses of radiation. She doesn't want to have eggs someday that have been radiated, where those babies may be abnormal. So she asks if that egg be placed, it'll survive if it's fertilized. And then fertilized, it can be frozen. And then what happens to that egg later on? If that person dies or decide they don't want the egg, or what more often happens is the couple that produced it argue over who should get it. And so there are more medical moral decisions to make there. Right now, I mean, there are certainly places in the world where they look at that egg and say, "Is this egg going to be a boy or a girl?" No, we don't want any more girls. They don't take care of you when you get old, and so they would try to select the child's sex before they're born. We have surrogate mothers. That's becoming very apparent now, because probably the country that did the most surrogate mothers of any place in the world was Ukraine. There are Ukrainian women just recently who are carrying somebody else's egg, and they're being paid $20,000 or so, which is more than a year's worth of income for that Ukrainian woman. And she carries that egg in the uterus, develops it, has the baby, and the people from the U.S. or one of the more affluent countries go and pick up their baby. And so we're seeing surrogate mothers. Where do we stand on that? Certainly when you lose a baby to save the life of a mother, the Catholic Church has never told us that that is an abortion. That's saving a life. And so so there's no question about that. We have one of the problems with government medicine is often when the egg is fertilized in the fallopian tube and never passes into the uterus. And so you have an ectopic pregnancy. Those ectopic pregnancies the baby usually grows to the point that it breaks the fallopian tube and the woman bleeds to death, and the baby of course dies. So there's never been an argument about removing the fallopian tube when there's a baby in it that's not going to pass, and it's not going to develop, it's not going to live, and would be fatal to the mother if it did. So we've said ectopic pregnancies are not something that there's any argument about. And now, just in the last year or two, we've come out with ways to alter your genes. We have the CRISPR technology. That technology is being used, and it's being used exceedingly well in medicine. We're starting to, as we get down to precision medicine, you have hemophilia. You bleed very easily. You have a good chance you're going to bleed to death before die of something else. Often when you're young, you can take care of that by taking a shot or a transfusion, but that's certainly inconvenient. It'd be a lot better to be normal. And we can take some of those hemophilic patients, have the gene we identified, we found the segment of DNA that's abnormal. We can take with CRISPR technology, replace that segment. The patient goes through wiping out their bone marrow, getting their bone marrow changed, getting it back into them, and they turn out not to have hemophilia afterwards. Most recently, there have been like 10 patients that had that done, and it made them normal. So some of the diseases we're working with are going to be treatable. Sickle cell anemia. We don't have many or any people with sickle cell anemia in Los Alamos. I think I've had 3 in my 50 years. They all went to lower altitude. They could not breathe here. They're saying when their oxygen tension would go low, which all of ours is now, they would sickle. That is, when they sickle, those red blood cells tend to form clumps. The clumps cause strokes. They cause pain, and those people are very uncomfortable if they survive at this altitude. So it's more in lower altitudes that people will move back to with sickle cell anemia. And now we're finding out sickle cell anemia has multiple genes, but maybe 10% have a gene that we can alter and make them normal. And which brings up not only that, but so many of the sickle cell people are black people. Sickle cell probably protected you when you had malaria in Africa, and you came to the U.S. and we don't have malaria, and you don't need that protection of those funny red cells that malaria parasites can't get into, and instead it's a problem for you. And so we're taking people that can't afford things and saying we have a way to help you. We have to find a way to help them that we can do it that's expensive and they don't have the money. And there's one case now in China that received criticism from all over the world, where a Chinese scientist took, and he's been ostracized by Chinese scientists and foundations as well, took an embryo in vitro, and then placed it in a woman, and she had babies. She had twins. She had two babies. The babies carry a gene that protects them from AIDS, and it was nice to show that he could do it. But there's other ways to protect yourself from AIDS other than changing your genes. But that's going to come up for other diseases in the future. And are we going to do that, or what's ethically correct? I don't have the answers for you.
I think we have about 10 minutes.
Okay. And now we're starting to use animal parts. We've used animal parts for some time. When I was a research fellow, we were looking at replacing aortic valves. We were trying human valves, and the human valves actually didn't hold up very well. Pig valves did better. And you can take and replace somebody's valve with a pig valve. You treat the pig valve, you take all the tissue out of it, sort of leave the architecture of it, put it in the patient, and your patient develops new tissue around that valve, and you've got a valve that was like the old one, except it's pig instead of people. And you can do that more with pigs than you can with other animals. They're genetically closer to us as far as rejection of tissue. We have used people who have large hernias or have a place where they need some tissue. You can use pig skin, and again treat it so you take the cells all out of it and use it as a structure to heal those wounds. We're starting to take from pigs, there's experiments going on where we're taking pancreas cells in the pig, make you so you don't have any immunity to get rid of those cells, and inject them into your vein. They find their way to the pancreas, and your diabetes goes away. So there's remarkable things that are being done with animal studies. And now there's a group in Virginia, and I think another one in Maryland, that made pigs that don't have one of the human genes, that are missing something. There's a disease called alpha-galactose, or alpha-galactose intolerance, where people, when they eat meat, when they eat lamb or they eat beef, any mammal meat other than monkeys, then they get an allergy reaction to it, and they are allergic to a particular enzyme that's found in the muscle of animals, except in primates, and so that we and the monkeys don't have that. It was researched and found. It was initially found by a friend of mine, the guy who helped us run the study in Los Alamos. There was a group in Boston that developed a new drug that looked like it would be great for ovarian cancer. Great drug, helped ovarian cancer, no reactions. So they sent it down to Vanderbilt. Vanderbilt was going to run some studies on the drug before its release. And Vanderbilt started having reactions to this drug. It turns out the drug was somewhat related to alpha-galactose, or the alpha-galactose enzyme. And the people in Tennessee had allergy to it. The people in Boston did not. It turned out it was a little red bug that bites people. You're bitten by these chiggers of Tennessee, and their saliva actually has some of this protein in it, and you become allergic to it. And so we look now for people who have what we've abbreviated and we call alpha-gal, and to help that, these companies are developing pigs that are genetically altered so they don't have alpha-gal. And the first one that had a heart transplant was just recently, this last year, where a man got a pig heart, somebody who was expected to die in a few days, and it took him a month or two to die. But at least it showed that the concept works, and he was willing to do that. He knew that what his odds were, and it was a chance that he was willing to take. So we're using pigs for other things. And in fact, the company now, you can buy ham and steaks from them, and they're pretty expensive. If you have alpha-gal, you can eat meat, but it has to be pork that's been genetically altered. And of course, you got your driver's license, I hope you checked the box that said that you're willing to donate your organs, because we're using a lot of parts of people now to keep other people alive and well. We have an ethics committee at our hospital. I don't know why, but they picked a couple of Catholic physicians and one Jewish person to be on that committee, and because they think that we have better ethics. And we activated again and put up some guidelines with the beginning of the COVID epidemic. The beginning of the COVID epidemic, and we only have 2 ventilators in Los Alamos. We have a couple anesthesia machines that we could keep you alive like a ventilator, but if we had 4 patients or 5 patients that need artificial breathing with COVID, the rest of the hospitals around were full and couldn't take them. What would we do? And so we had to set up a set of guidelines what we would do. And our guidelines had some inclusion criteria. First of all, you had to have an advance directive saying you wanted to be kept alive, or your family or somebody helped to decide that. We'd look at their prognosis and their physical status, and there were several scoring out there that you can look and see, and you can put in the patient's age, you can put in the patient's disease, you can put in the blood pressure, you can put in their level of several enzymes in the blood, and you'll come up with an answer and a number. And if your number was lower or higher than somebody else, then that would help us decide which patient would get on the ventilator. And if we finally got down, if everything turned out the same, and it's kind of unlikely because you can do several scores and they all have multiple entries. But if it came to the same, we went out flipping a coin and seeing who would get the ventilator. And then we reassess that every day if we get in that position. We never did, fortunately, in Los Alamos. We never had more than 2 patients on ventilators here during the height of the COVID epidemic. So what's coming down the future? Basically, sexuality is something that's coming down for both medicine and for the church. Our lesbian, gay, bisexual, transgender, queer, intersex, asexual. I mean, the intersex has been around publicly for a long time. I remember when I was in medical school, one of our professors had essentially a show and tell. I'd show pictures of the genitalia of newborns and have you guess if it was a boy or a girl. And a lot of times you guessed wrong. When you looked at the genetics of the swab of the cheek to see what the sex of the baby was. There's some babies that are born looking different than what they really are. And you had to make, and they had to make a decision at that time with surgery at the time, shortly after the child was born, that they should try to make that baby into a boy or a girl. And so we've had intersex problems like that as long as we've had people willing to do surgery and correct things. So we're using devices. We have things now that if you lose your leg and you walk on a spring, you do better than other people. And so that we have to look at things that we have to decide the ethics of the use of some of these devices. The expense is a big problem. We use a lot of biologics in my office. It turns out that biologics have been essentially almost curative for people with asthma, people with terrible hives. Biologics run somewhere between $30,000 and $50,000 a year. And the genome. What are we going to do about the genome? If you have relatives who have Huntington's chorea disease, your chance is 50% of having the gene. Do you want to know? Does your doctor want to know? Does your insurance company want to know? And so we have to learn how to handle the genome. Were there things we're doing that people live longer? Should we be doing those things? We're getting a lot more old people than young people. And what bothers me the most is I'm an old doctor, and I think every time, I remember when I went into practice, the old doctors were talking about how bad Medicare was for a year or two. And then they realized that all these patients they were taking care of for free were paying. and they stopped arguing about it, talking about how bad Medicare was, and now they defend Medicare. But we've seen medicine change into a business ethic. We only have 1 or 2 hospitals left in New Mexico that are non-profit. They've all been bought by profit organizations. The profit organizations are run by investors, not by physicians. not by nurses, not people with medical backgrounds. They're, how can we make more money out of this institution? So we've seen that change in Los Alamos as well. That people will do more things for you to make more money rather than to help you. And so we see that medicine is becoming more, to me, becoming more of a business ethic than a service ethic. The physicians now, we can't find doctors to go into private practice in Los Alamos because they can get paid more and they do a lot less paperwork if they're in an organization or working for a hospital. Santa Fe hasn't had a primary care physician come in several years now. They've all come in and worked for the hospital. And so often they come in because they get a signing bonus. They work for the duration of their signing bonus, and then they go someplace else and get another signing bonus. So we see a lot of changes in medicine that are happening, and it's hard for me to decide when we try to do a service ethic if we can continue to practice medicine the way we do. And so I'd end with William Osler was the chairman of medicine at Hopkins, and he went to become the chairman of medicine at Oxford, and they knighted him. So it was sort of the father of internal medicine. The practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. And that's all I can tell you about medical ethics. Thank you.
I don't know who has the more difficult ethical job, one in the medical profession or a nuclear policymaker. About one or two questions before we break for lunch. Ken?
I was looking at your last slide, in calling in which your heart will be exercised equally with your head. And that addressed, to some extent, one of the conflict you mentioned, professional versus personal. Because when you exercise your heart, it's highly personal. So there's a conflict there. How do you resolve it? When does something become professional? Is when there's enough doctors on a committee agree, then the professional value change, or does it not change? Even though although the committee agrees, but those practice physician may not agree.
But I think that that's medical ethics. That's where we have to take these things into consideration and use our ethical principles to decide. When I was a research fellow, my immunology lab was next to the kidney lab. Kidney lab was developing dialysis at those days. It was in Seattle where they did their first dialysis. We thought they could pick up 8 patients to see if they would keep these people alive. And they had to decide which 8 patients, there were hundreds of patients out there that needed kidney dialysis, which ones should they pick to try this experiment to see if they could help them. And they ended up with a set of guidelines much like we have. They did have a few things there. It favored you more if you had children, favored you more if you were a mother. But they had to set up a set of ethical guidelines and make that decision. And those are things that we have to do most daily. People come to me and I want to recommend something to them that's going to be expensive for them. And we have to decide, is there another way we can do it? You won't be doing it quite as well, but it'll be cheaper for you and you can afford it. So I think we make those ethical decisions in our practices on a daily basis.
Jake?
I'll put you on the spot. Also, please use the microphone so you want to hear.
That's good. Thank you.
Do you think that Catholic theologians are adequately keeping up with what medical science is finding out?
I can't answer that, but I can go back to my medical school days. My medical school had a book that showed you the development of the embryo. Human pictures of babies. I thought, golly, are these all babies that have been aborted? This book came out of Loyola University in Chicago. And there were two physicians there who went through every uterus that they took out of a woman for another reason. And the woman didn't know may not have known she was pregnant. And they were able to establish the stages of the embryo. So the real data that we have at first about the stages of the human development, what the embryo looks like at various early weeks of their life, came out of a Catholic university. And so I think that the Catholics are, if anything, we're probably ahead of other universities in that. I'm sure that Georgetown, I'm sure that Creighton, and all have very strong ethical departments and opinions. And Father's going to either answer or ask me another question.
Not really. In the Catholic Church, is that your question? In the Catholic Church, we define imminent as something 100 years or less. So what happens is medicine and science move so quickly, and it's become an issue with end-of-life care, you know? I mean, the current doctrine of the Church, I believe, is that we will not deny nutrition or hydration, right? But what do you do in a case where the kidneys aren't functioning? You can't pump it. You look like a Pillsbury Doughboy in bed here in about a week, you know? So we haven't, I don't think the answer, but I think we have kept up. And I think we probably need to make a better effort. But again, that imminence 100 years, so we've been around a while, and we're not adept at reacting quickly sometimes to important changes.
Good. So it answered Chick's question. I told him when he came in, don't ask any questions.
That's the first time I ever answered your question.
Very good answer.
Thank you.
Well, Dr. Honsinger, here's your patient. I want to thank you for your care for him. I think we should break for lunch, but I do want to thank our morning speakers, Ray and Dick, for demonstrating, both of them, in very different but very important realms, how important it is for lay Catholic scientists and professionals, and all of us in the Church, to educate ourselves about our faith and be good examples of how to live it and practice it in our lives, in our professions, for not only our good, but the good of all of our neighbors.